Welcome to 5 Things to Know, a new webinar series from Allergy and Asthma Network. Today's webinar is titled 5 Things to Know About Asthma Issues at School. I'm Sally Schoessler, Director of Education at Allergy and Asthma Network, and I have a long background in school nursing. I've served as a school nurse teacher, a state school nurse consultant, Director of Nursing Education at the National Association of School Nurses, and I bring that strong history and love of school health and students to my work here at the network. The 5 things that we'll be covering today are asthma at school, asthma meds and tools. Now we could do a whole hour just on number 2, but we'll present an overview. Then our number 3 is going to be stock albuterol for schools, 4, making stock albuterol work, and number 5 will be highlighting resources for you to use. Allergy and Asthma Network was started in 1985, so this year is our 35th anniversary, and we're very excited about that. What's really cool to me about the Allergy and Asthma Network is that it was a real grassroots patient advocacy organization. It was started by a mom who couldn't find any resources and help out there for her child with allergies and asthma. So she worked hard to develop this network, and she was started out typing newsletters at her kitchen table. But these days we're working to develop patient-centered care teams, and we work with leading experts in the field, and our goal is to support patients and families. Our mission is the Allergy and Asthma Network is the leading nonprofit organization whose mission is to end the needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. We're excited to have Ann Connelly with us today. Ann has been licensed as an RN in Ohio since 1981. She became a licensed school nurse in 2001 and a nationally certified school nurse in 2008. She worked as a school nurse in Newark City Schools in Ohio. She became a school nurse consultant at the Ohio Department of Health in 2006 and supervisor of the school nursing program in 2008. In addition to her school nursing program work at the Ohio Department of Health, she has also overseen Ohio's Personal Responsibility Education Program, or PREP, and has been the principal investigator for the CDC Asthma Grant Program at the Ohio Department of Health, and is currently overseeing their Early Childhood Health Program. She received her bachelor's in nursing in 1981. Now you notice, Ann, I left off the years of my education because I don't want people to start adding up how old I am. Anyway, so she got your bachelor's in 1981 and your master's in nursing with concentrates in school nursing, parish nursing, and family and community nursing in 2001. Well, we're going to hear from Ann in just a few minutes, but Ann, we're so glad you're here with us today.
Well, thank you, Sally. I'm really happy to be here with you all, too. I will be chatting in just a minute.
Great, thanks. Okay, we're going to just look at a few asthma facts to get us going. We are looking at 22 million Americans diagnosed with asthma, but this number has grown. We're really much more at 26 million. And so that is a big chunk of our population. And the other interesting statistic is that 1 in 10 children in the United States has asthma. Now, in a school, that would mean that out of a classroom of 20, you'd have an average of 2 children with asthma in every single classroom in every single school across the country. The annual cost is topping $81.9 billion. And the next statistic is one that I wish we could see go away. This one, it pains me to no end, and that's that we still see over 3,000 deaths annually from asthma. And that comes out to being almost 10 deaths a day. So, and then the other data point that is just dismaying to me is that the death rate is 75% higher for Black persons than white persons. And very frankly, we've got to do something about taking care of these asthma disparities. So it's the #1 reason that children miss school. 13.8 million missed school days per year. And if we want to help tell schools about how we can support test scores, we can help keep children with asthma in their seats at school and make sure that it's no longer the #1 reason that kids miss school. There are 14.2 million missed work days per year, and that's not only adults who suffer with asthma, but those parents that have to take time off to care for those children that are missing the 13.8 million school days each year. 3 in 5 people with asthma limit their physical activity. I think this is something we can use as a real education point as well, because if your asthma is in control, there should be no limits to what you can do. A study was done recently. The stat here says 71% of people misuse their inhalers. There was kind of a frightening statistic of how many doctors who had trouble teaching correct technique for inhalers to their patients. But these are difficult little contraptions. And I think this is another thing where we can really make a difference, is making sure people are using them correctly. And another thing we can also help to impact is that 1 in 5 people cannot afford their medications. So which of these data points surprised you? I think there's a lot here that could be very surprising, but I think the thing I just want to repeat one more time is that no one should die from asthma. And certainly at school, we want to be really making sure that never happens. So our first point was going to be asthma in schools, and Anne's going to speak to you and give you a quick overview of asthma, look at prevention, treatment, and management, and issues related to the school setting.
Thank you, Sally. I think, as Sally mentioned earlier, asthma is one of those things you could talk about all day, all week. There's a lot to know about asthma, and we're just going to hit the highlights today. So understanding asthma in general, just the thumbnail overview, is as you see here on the slide, asthma is a syndrome rather than a single disease. I think one of the reasons it seems so complicated or frustrating for families and school staff, for instance, is because every person who has it is just a little bit different. As you see here, the hallmark of asthma is inflammation, but what causes that inflammation? What leads to that? And there's a complex interweaving of, as you see, environmental and genetic factors. That inflammation causes the airways of the person with asthma to be hypersensitive and hyperresponsive to any kind of stimuli, such as the triggers, and that causes the clinical symptoms of the coughing, wheezing, and dyspnea. And as you know, it should be, we hope, unless it's one of those awful situations where the person dies, but it should be a reversible airway obstruction. This is not, you have episodes where the symptoms get worse and then they improve with treatment. Asthma is a chronic disease of the respiratory system in which the airway becomes constricted because of the inflammation and the excess mucus. And actually, you can see here perfectly in this picture, as you look at the picture on the side, you can see the airways, and that pink lining is what becomes thickened during an asthma episode. And the little green mucus you can see becomes thicker and clogs that up. And then you can see the brownish bands around those airways, and those are the muscles, and those constrict. So when all three of those things happen, then you have difficulty breathing. But I do want to step back a second first and talk about the difference between quiet asthma and noisy asthma. As I mentioned, asthma is a long-term chronic illness. It doesn't go away. It cannot be cured, but it can be managed. And when you have asthma, some people are aware of asthma episodes and think that that's the only time they're having asthma, that they don't have it the rest of the time. It's just once in a while. But really, the airways remain sensitive and can easily become inflamed all the time. They're always more sensitive than the average person. That's why it's really important to take the daily controller medication. We'll talk more about that later, and avoiding triggers. But that's the quiet part of the asthma. You're not aware of what's going on. Noisy asthma is what people often think about, often call asthma episodes or asthma attacks. Sometimes you hear that. This is, again, when you have that swelling of the lining of the airways, increased mucus production, tightening of the airway muscles, which leads to coughing. And particularly at night, often you'll have people with asthma who cough and cough and cough all night long. They don't sleep well. They may keep their family members awake. That is a hallmark of asthma. Wheezing, sometimes that's audible with with the naked ear, so to speak. Sometimes you have to use a stethoscope to hear that. Chest tightness, they feel like they're having like something sitting on their chest. And then, of course, shortness of breath. Causes of asthma is a little bit more difficult to address specifically. So, for instance, the causes are not completely understood. Again, as I said a little bit earlier, it's probably a combination of genetic and environmental interactions. And some of the things that we know are related to a person having asthma include a family history. Do other people in the patient's families have asthma? Exposure to secondhand smoke, especially when children are young, that exposure to secondhand smoke can really sensitize those airways and make them more likely to have asthma. Other environmental irritants can do that. Children who live near freeways are more, for instance, are more likely to have asthma. And children who are born prematurely have a higher risk of asthma. Triggers are very individualized. Triggers are what the person's airways react to. So that's the thing that's in the environment that the person who has asthma is exposed to that causes that collection of symptoms with the mucus and the tightened muscles and the thickened airways, or the thickened lining of the airways. The most common triggers are allergens such as pests, like cockroaches or dust mites or those kinds of things, dust in general, mold, mice, again, those are pests, pets, not pests, but pets, cats are often a trigger for people with asthma. It may be something in the carpet or the actual carpet in someone's home. Irritants such as smoke, I mentioned already, air fresheners, essential oils that people are trying to diffuse to make the environment better. Those are problems. Smog, perfume, bleach can be an irritant that causes an asthma episode. Then there are other things such as exercise, cold air, stress, and viruses. Each person has their own triggers, and one of the challenges about asthma is identifying them for the person, helping them identify what their triggers are, particularly if you have a young child, because it takes a while sometimes to identify what the triggers are. And then when you talk about asthma control, the hallmark, the most important thing for asthma control is to have an asthma action plan. Everyone who has asthma should be working with a healthcare provider to develop an asthma action plan. Sometimes you hear those referred to as the red, yellow, green plans, and they include what kinds of daily medications that the patient or the student, in this case we're talking about schools, should be taking, what their triggers are and how to avoid them. And then if they start having symptoms or get into that emergency situation, what they need to do to care for that episode. Sally will talk more about medications later, but it's always important to emphasize that students need to take those daily medications. If they're prescribed those daily medications that they take during the quiet phase of asthma, they need to do that. Sometimes people take them for a while and the treatment is successful and they think, oh, I'm cured, I don't need to do this anymore. And then they have an asthma episode. So it's important to take those daily medications all the time. They need to, again, avoid triggers, observe for symptoms so that they can be aware of when they need to use their additional medications. They need to promptly treat episodes. If, again, they've been paying attention to their symptoms and notice they're having them, then they need to treat them promptly. And they also need to visit their healthcare provider regularly. It's important that they go back on a regular basis to touch base, evaluate the symptoms, how they're managing things at home, to talk with their healthcare provider and see if they need any changes in their medication. That's an important part of asthma care. One of the challenges with working with children is what I call, where is my inhaler? Often, children being what they are, they don't know where they are. Is it in their backpack? Is it at their dad's house? Is it at their grandma's house? Is it at their mom's house? Did they leave it at a friend's house? Where is their inhaler? It can be a search. Prevention, as I mentioned, trigger avoidance and assess the environment. Again, it may take a little while to identify what a specific individual's triggers are. Again, assess the environment, see what's there, and see what's present when someone has an episode to help identify what the problem is. And then once you know what their trigger is, again, reassess that environment and make sure that the trigger's not there so they aren't having problems. For some students, for some people with asthma, there is part of their treatment is to pre-medicate before an intense activity. So for instance, a student with asthma who runs cross country, they may be instructed as part of their care to go ahead and pre-medicate with their inhaler before they do their run. Treatment, again, the asthma action plan, that's really the key to how to manage asthma. And you can see here the right medication, the right device at the right time. One of the challenges that you may find is that families have trouble. They may have an inhaler that they take on a daily basis and a, quote, rescue inhaler that they use during an episode. Which inhaler is which? Sometimes you find they've been using that rescue inhaler on a daily basis and not using their daily medication because they've gotten them confused. So that right medication, right device at the right time is really important. Management, then, you see, is education. You need it to be developmentally appropriate. But there are a number of people that need to be educated about asthma. The child is one, so of course you need to make sure that that is developmentally appropriate and they understand. You also need to be sure to make sure that the family is properly educated. Are there other caregivers? Do they spend every weekend at grandma's? Does grandma need to know how to take care of things, what asthma is? Or do they go to childcare after school? That person needs to understand what asthma is and how to take care of it. And if you have particularly young children, or if you have a preschool program in your school, make sure that those staff understand about that too. And school staff, the appropriate school staff need to be educated about that. Working towards self-management, the last thing on that slide is that our goal for children in general, for every kind of chronic illness, is working towards self-management. You want them to grow up and understand their disease and be able to manage their own health as they go forward. Okay, now you can go, Sally. So for school issues, there are a variety of things for you to think about. First is planning, and there are a couple of different ways to look at planning. One is that the school overall needs to do some planning about asthma. For instance, having policies in place such as no bus idling, being 100% tobacco free, encouraging parents to turn off their car while they're waiting in that pickup and drop off line. So those kinds of policies will help keep all the students in school. It'll improve the air quality for everybody in school. And again, asthma action plan is part of that planning. It all starts with that. You need to work with the family and the healthcare provider to understand the student's needs, their triggers, what their medication should be. Coordination of care, I already mentioned working with the family and the healthcare provider, but also identify which specific school staff should know about a specific student with asthma. As you know, confidentiality is always an issue when you get into schools and talking about children's personally identifiable health information, but you also want to make sure that the student is safe in school. So you need to identify which school staff really need to know about a specific student and share their asthma action plan, their emergency action plan, and make sure that the school staff are prepared. Staff education involves that, but also if you have the opportunity to do generalized staff education, teach the entire school staff about what asthma is, what the symptoms are, and the importance of prompt care. Make sure that any teachers don't send children to the school nurse's office alone. They should go with somebody, accompany them to the school nurse's office. Safe environment, we've talked a little bit about that with policies, but it's also important to check that environment for triggers. And again, I mentioned the essential oils and air fresheners. Teachers use these things with the best of intentions to try and make the environment more appropriate for kids and help them with their learning, but that can really be a problem for kids with asthma. And then emergency response preparation. Again, make sure that you have staff who are identified and trained to act in case of an emergency, really any emergency, but specifically so they know how to work with a student with asthma. And be sure if unfortunately you have an emergency situation and things happen, be sure to debrief afterwards with your team to identify ways to improve that training and response in the future. And finally, as school nurses, you should all be familiar with this framework for the 21st century school nursing practice. This is from the National Association of School Nurses. And as you see on the side, it says asthma management can be found in all categories of this framework. So this student who has asthma is there at the center. The school nurse's role is in care coordination, coordinating with the family, the healthcare providers, and the school staff. Leadership, volunteering to help develop policies, training all your staff about asthma and training specific staff about specific students. Community and public health, making sure that you as the school nurse know resources in your community so that you can refer families as appropriate. And quality improvement, always ask, how can we do this better? Use the plan, do, study, act cycle if you have the opportunity to do a project that way. And of course, always use the nursing standards of practice.
Okay, our number 2 is we're going to look at asthma meds and tools. We're going to look at respiratory treatments and respiratory tools. And as I said before, we could spend a whole day on just the meds. So we're going to give a little bit of an overview and help you figure out where to find more information if you need that. So what is the goal of medicating a child for asthma? And that the first goal is you want to prevent and control any asthma symptoms. You want to make sure that if they're having an asthma issue, or we call it an asthma flare, that you're going to make sure that you relieve those symptoms and help them be able to breathe. You're going to want to reduce the frequency and severity of asthma flares. If you have a student who is coming down to you constantly, well, now there's something else that's going to have to be done. And helping the parents navigate the healthcare system to make sure that they get their child what they need and the right medication. And as Ann said before, the right medication in the right device at the right time. And sometimes that's a lot for a family. You also want to make sure you're reversing airflow obstruction. These children are going to want to use their lungs for a lot of years. And if their asthma is severe and untreated, they can have that airway remodeling and they can then have irreversible damage. But, most of the time, any lung damage that comes from asthma is reversible with a good medication and good control. So ultimately, we want to prevent the progression of asthma and the development of that irreversible airway disease. So asthma medications, they align into two categories, the quick relief and the long acting. And when we're talking about quick relief in inhaled medication, we're talking about those short acting inhaled beta-2 agonists, or we call them SABA. And it's kind of every profession seems to have like their own little language and their own acronyms and everything. So I tried to make sure I wrote things out and then put the acronyms so that it wasn't so difficult to look at. Also, anticholinergics fall into the quick relief. We really are getting away from saying rescue medications. And Anne alluded to that before when she kind of, was like, in quotes, rescue medications, because we want people to understand that they can get quick relief from them. They're not only for when they're going to need to have when they're having an emergency. And then long-acting medications. And these are going to be your corticosteroids, both inhaled and oral. And I think it's really important that when you're educating families, they hear steroids and they think bodybuilders and they think anabolic steroids. And it's like, oh, no, no, no. These are corticosteroids. And an inhaled corticosteroid can be fabulously amazing in a child's treatment plan and really help them keep their asthma in control. We do want to make sure that we're encouraging as few doses of oral corticosteroids in a year as we can, because these do have some very lasting side effects. So there are certainly differences, between the side effects and the safety of an inhaled corticosteroid versus the oral. There's also non-steroidal anti-inflammatories, and then we have the long-acting beta-2 agonists, or the LAMAs. We have leukotriene modifiers that fit into this category. And then the long-acting muscarinic antagonists like the LAMA. But you're not going to see those really in children because those are more related to COPD or chronic obstructive pulmonary disease and asthma. So I took my Asthma Educator test and certification about a year ago and thankfully passed it. But so I'm just not a great test taker. But these are guidelines that virtually had to be memorized in order to work really well with all of this test. So you want to be thinking about, this comes right out of the asthma guidelines, and this is talking about how we can help children, go through the different steps that they might get into as their asthma might progress in severity. So with step 1, this is your child with intermittent asthma. And this is going to be the student that you see, a few times a year. And maybe, this is the child that you definitely see the day of the mile run at school, because that's when all the children with asthma come out of the woodwork to get their inhalers. And the preferred approach for treating intermittent asthma is that SABA, which you just give on an as-needed or PRN basis. If they need more than that, if their asthma is more of a persistent situation and they're going to need daily medication, you're going to want to think about they'll get moved to step 2 by their provider. And here's where they're going to get that low dose inhaled corticosteroid. There are always alternatives at the bottom of this chart, but pretty much you're going to see what's in the blue box with the red line around it. For step 3, again, if they need more than that, they might have that low dose inhaled corticosteroid plus that long-acting beta agonist, or a medium dosed inhaled corticosteroid, and which I'll use ICS for now that I've said it 4 or 5 times. In step 4, there you're going to definitely have a medium dose ICS plus the LABA. In step 5, you move to a high dose. And now you're getting children who are really struggling with their asthma. And so they should really, once they really get to a step 4 or higher, they should be seen by an asthma care specialist if they can be. And then when step 6, you get up to the high dose of the ICS and the LABA, and sometimes an oral corticosteroid is added here. The other thing that can be considered for students that are in step 5 and 6 is looking at a biologic medication. There's a lot of them out there, and they address different issues in the cells, way down to the cellular level. But you can certainly consider omalizumab, which the trade name is Xolair for children, and this is approved for children 6 years and up. So the biologic might be something that you're hearing about. They won't have the biologic at school, but you might hear that they're on that. So that's something you would want to be aware of. So if as control is being assessed in a student, they might need to take steps up as they go to their provider. But then also, if they've been in control for 3 months or more, on that treatment, you want to try to step them back down and see if that can be a good move for them. And at each step, you want to think about patient education. You want to think about that environmental control of triggers, and then the management of any comorbidities that they might have. And I think one that really comes to mind a lot of times is obesity. So this is when the Allergy and Asthma Network's respiratory treatments poster. And when I was a school nurse, this was my first connection with the network. I was like, I love this poster. I have to have this poster. I cannot take care of children without this poster. But we revise it about every 6 months, and every inhaler is on this. And so you're going to see all those different categories. At the top on the left, you're going to see those the SABAs, and then on the right, you're going to see the LABAs, and then you can see all your other categories. And we've got the biologics on it, and then you're not going to be dealing with bronchial thermoplasty at school, or really the PDE4 inhibitors. But where your time is going to be spent really is mostly right here, because these are going to be those quick relief inhalers that will be coming to school and staying there. The rest of them tend to be more of the once a day that's going to be taken at home. Now, sometimes they might bring a medication that it's their controller medication to school if the family simply cannot quite manage giving it. But usually families can handle that pretty well. I just want to ask, if you haven't seen it, if you look at that first box under the short-acting beta-2 agonists, you're going to see ProAir Digihaler. And if you have not seen a ProAir Digihaler and you get a chance to, they're very cool. They have a Bluetooth connectivity to a mobile app, and it detects how often the inhaler is used, and also it measures the inspiratory flow as well. And you can share that information on a daily or weekly or monthly report to the caregiver or the provider. So that is just a really cool kind of like cutting edge type of thing. When we're looking at these beta-2 agonists, their actions, they're going to have a quick onset within minutes, and they're going to last 4 to 5 hours. It's going to relax that smooth muscle, and so you're going to not hear as much of the wheezing and the coughing. It's going to reduce that mucus viscosity that's plugging up all the airways, and it's also going to inhibit mast cell degranulation. Now, the adverse effects that you might see are that students might be a little tachycardic. They might have a little bit of a tremor from the medication. And obviously, we're not going to at school measure their blood glucose and lactate levels or their serum potassiums, but you do get a rise in the blood glucose, and you get a reduction in the serum potassium. Now, this could also be something you definitely would want to know if the student had asthma and diabetes. That would be something that would impact the other. So one thing that every student should know about their medication is not only the name and the appearance of their medication, and that's also where that poster comes in handy, because I can't tell you the number of times that students came in and they said, I had my inhaler this morning. And I would say, well, like, which one? And they'd say, oh, the red one. And so, but they could show me the picture, and then I'd know whether they had their controller or whether they had their quick relief. And that makes that really a fun tool. But they should know the name of their medication. They should know what it looks like. They should know what their meds do. They should know how to use their meds. And they should also know what will happen if they don't take it. Those are all really important things to consider in your teaching. And these can be done while you're giving the medication. You can even have some fun and put their inhaler with some others and say, okay, which one do you think is yours? And see what they do. And so you can have some fun with this as well. One thing that we have on our website is demonstration videos for using inhalers and devices. And in anticipation of this webinar, I got an email from a school nurse that said, please, please, please show, help us understand how to show people how to use their inhalers. So here we go. So if you look on our website, these are all from National Jewish Health, but they have about 25 to 30 of these little short videos, and it shows you how to use different inhalers, shows you how to use a nebulizer, how to use a peak flow meter. It shows you how to use a spacer. So these are fabulous, and you certainly can pull these up right at your desk and have a child watch them and then emulate the action that they see. So we're going to look next for a minute here at stock albuterol for schools. This is our number 3 today. And we're going to look at where there are laws and what this means for school nurses. Stock albuterol is moving across the nation. When stock epinephrine was first being passed, those laws were first being passed, we literally saw a change in 2 years from a map that was very spotty to one that was absolutely one color, and they were all that there were laws in place. Now, still with the epinephrine, there's only one state that doesn't have state laws, and that's Hawaii. Now, I keep offering to go to Hawaii to make that happen, but nobody has sent me yet. But when we're talking about stock albuterol, it is on the move, and we're working with a lot of states to try to make this happen. 10 states have stock albuterol laws, and 3 states have guidelines for using stock albuterol. So most states will allow the use of stock albuterol rather than mandate it. And so it's going to be really important that you know what the status of a stock albuterol law is in your state, but also what does it say? You know, what does it say about allowing or mandating? What does it say about any Good Samaritan protection for school staff? Who do they allow you to give it to? Sometimes it'll be for a student only that has a diagnosis of asthma. I would like to see it be able to be used for those students that are having their first asthma flare and they don't know that that they have asthma and they are having distinct trouble breathing. So, but when we're talking about stock medications, this little graphic here, we made it for when we were doing a stock epinephrine implementation toolkit, but we're going to revise it for albuterol as well because these 4 P's still apply. And that's, so every time you see epinephrine, I'm going to say albuterol, and it's not like I can't read. I really do know that I'm replacing the word here. But the first P that we need to think about is policy. And your school district really needs to adopt a policy to guide the use of stock albuterol. And then the second one is protocol. And school district should really help develop, if you have a medical director, or even if the school nurse wants to get with people that do this. And then there are things from other states that are available. But you really need to have a great document that's going to say when you should use the stock albuterol. Another issue, and this is one that a lot of people struggle with, is who's going to write the prescription. And you can certainly identify a prescriber to write the prescription and the standing order to give it. We've talked to the American College of Allergy, Asthma, and Immunology, and they are doing a project right now where they are going to develop a toolkit for the prescriber. So it's almost like step by step how to do this. And I think it's going to be a fabulous tool. They already have one for epinephrine. So we asked if they would create one for albuterol, and they said they thought that was a fine idea, and they're working on that. The other thing to keep in mind is if you ever have trouble finding a prescriber, we know allergists in every state that will write a prescription and help. So we can be a resource to you in that way. And then you need to develop partnerships. The administrator and the school nurse need to really be on the same page to implement stock albuterol, not only with school staff, but just all the little pieces of it that go together. For school nurses, this is all, I think, part of care coordination. And I think every time an RN is in a building, they should really stress to people that what an RN brings to every student interaction is assessment. We have assessment skills that we can be there to really do a really sound, evidence-based assessment of a student's condition. But we need medication to be available when we need it for a student. And asthma flares should be cared for before they can become an emergency. Now, a professional issue. Again, I didn't want to talk about the dates of when I got my nursing degree because I don't want you to be able to add up just how long I've been around. But I was a school nurse long before there was stock medication available. And we were faced with very difficult decisions some days. Would you watch a student who is in respiratory distress continue to suffer and possibly start to turn blue? And that's a late stage symptom. You know that child is in deep trouble then. So do you act? Do you use another student's medication, which is outside of your scope of practice? Or do you hope that the ambulance, the EMS, gets there in time? This is a terrible conundrum for a school nurse to be in. So that's part of the beauty of stock medication, is it takes this whole issue away, and the school nurse is not faced with what to do. And so that's one of the big reasons I am a big believer in stock emergency medications. So Anne, you're up again with making stock albuterol work.
Thank you, Sally. So we're going to talk about challenges and barriers in implementation. In Ohio, the law that addresses stock inhalers is Ohio Revised Code 3313.713, and it's called Procurement of Inhalers by Board. I'm sure you're not going to go look that up immediately, but the link is there if you do have that desire. It was effective in February of 2016, so we're just a couple of days shy of that being 4 years. And in Ohio, this law is what's called permissive, which means that it is not mandated that schools have inhalers, but they are allowed to procure stock inhalers for use on anyone with asthma symptoms on the premises. And as we go through this, our law in Ohio refers to them as, quote, asthma inhalers. So really, what else would it be but the albuterol? But I may flip back and forth between the terms, and that all means the same thing. So it requires a prescription, a protocol, and staff training by a licensed health professional. And if someone besides the licensed health professional, the nurse or the athletic trainer, is the person who actually administers the inhaler, then they are required to call EMS. If it's a nurse or an athletic trainer, they are considered competent to be able to assess whether or not they have been helped enough to not need EMS, or if they should go ahead and call. Ohio school law allows any school staff who have been identified and designated, trained by a licensed health professional, to administer that, and that includes unlicensed assistive personnel, or UAPs. Ohio nursing law, so the Ohio Nurse Practice Act, allows anyone to administer a medication in an emergency situation. So it is addressed in more than one place in Ohio. And again, make sure to pay attention to what's going on in your state. What I'm talking about is specific to Ohio, so you need to make sure that you understand what the situation is, what the law is in your state, and how laws interact. Some districts in Ohio some districts have medical directors, but some do not, because it's not required. So schools have been able to build upon the successes of their stock epinephrine laws. Sally had mentioned that earlier. And if they had a relationship with a doctor, whether it was their medical director or some other prescriber, if they had that prior relationship, they could go ahead and build on that relationship to get a prescription for the inhaler. It's helpful to know the asthma prevalence data for the district, because when you're able to figure out how many kids actually have asthma, and then that really is a strong selling point for why you should be able to have a stock inhaler. The Ohio Association of School Nurses and we here at the Ohio Department of Health worked together when this law was new, to develop a sample protocol and a policy that schools could adopt, and then they could use that as their basis to develop their own protocols and policies about how to implement that law. And that's available from both of us. It's available on our website at OASN's also. One of the practical differences, or maybe impractical differences, between the stock epinephrine auto-injectors and stock inhalers is epi is a one-dose container. There's only one dose in there. That is not true, of course, with inhalers. So part of the putting together policies and protocols is addressing how do you manage something that has more than one dose that potentially could be used by more than one person. So some of you may be aware of Dr. Dave Stukas. He is an allergist who is here in the state of Ohio, and He's active on Twitter. I would encourage you to follow him. I think he's at Allergy Doc as his handle, but he's great.
He's fabulous.
He consulted with a lot of different districts here in the state of Ohio and talked to them about spacers or holding chambers. If you have a spacer with a one-way valve, you can use that. Use this inhaler, put the kid's name on the spacer, keep that or give that to them, and then use another spacer with the next child who needs that. So he's worked with several different districts to set up that kind of a situation. And that last bullet is making sure local EMS is aware. One of the school districts, one of the large urban districts in our area, had a challenging experience working with their local EMS when this law first went into effect, because EMS didn't know what was going on. They didn't know this was a thing. They didn't know that the law existed. There were some discussions, I'll say nicely, between the nurse who had called the squad to transport a student that the nurse had evaluated and decided needed to be transported, and the folks in the squad who came to pick the child up, who said, well, I don't know, I'm not sure that they need to go. So they had to work that out. Some barriers, school board approval. One of the problems, one of the challenges with getting this kind of thing in place in a school is school board approval. And they have so many competing priorities that it sometimes is challenging to get their attention to get this kind of a thing in place. Again, I already mentioned about finding a prescriber. And for a period of time when these stock laws first came into effect in Ohio, a lot of the prescribers had some concerns about liability. They did go back and the legislature did go back and update the laws so that it is obvious that they have limited liability, but that has often been a concern. Funding, I'll talk a little bit more about that later, but funding, of course, is always an issue. And then hesitancy by trained and unlicensed staff. Despite the fact that UAPs are by law allowed to be trained and administer this, we have found that most of the time it is an RN who goes ahead and administers this medication. So hearkening back to Sally's 4 Ps, some of the things that we've learned in Ohio in the last 4 years is policy. I already mentioned the competing priorities can cause a delay in adopting policies by the school board. There is a group called Neola, that's their entire name. It used to be an acronym, but now that's their actual business name is Neola, and the Ohio School Board Association, both of which create policies, and schools can purchase those policies. They can essentially get a membership and use their policies. So those are 2 places that have had a lot of effect around the state as far as policies, putting policies in place. So that does make it easier for schools if they work with either of those groups. Protocol, that does vary among districts. It can include the use and labeling of spacers or holding chambers, as I mentioned, to enable multiple uses for one inhaler. It can include algorithms for both the school nurses as well as UAPs. And then again, I already mentioned about EMS. EMS is required to be called by anyone who is not an athletic trainer or a nurse. Data collection efforts within the district. A lot of districts have put together a paper reporting system so that particularly with the bigger districts, if the inhaler was used, they will fill that out. The person working with the student will fill that out and submit that to the central office so they can track what it's used and when it's used and those kinds of things. One district I know talked about using telehealth so that if the nurse, because many nurses have more than one building that they serve. So if the nurse was at a different building, they could, the UAP at the school could get in touch with them via telehealth, and that nurse can weigh in on helping assess that patient and determining what needs to be done next. And of course, you always need to think about, where are you going to store this? How are you going to distribute it in the district? How are you going to make sure you have the appropriate number of spacers for each inhaler? Prescriptions, again, I have alluded to that already. Some schools have a medical director who can write, but honestly, many allergists in the state, and Sally had mentioned this already, had volunteered and told our school nurses that if you are having trouble getting a prescription, get in touch with us, we'll write for you. And partnerships, again, consulting with that allergist. I mentioned that several districts in Ohio consulted with Dr. Stukas. So consultation with that allergist and other experts to help identify best practices in the state can help with that, can help you get things in place. Funding. Always a challenge for anything we do in schools. While one of the advantages that epinephrine auto injectors have is that the manufacturers have giveaway programs for schools. That is not the case with inhalers. So there is not one company that has said we will have an inhalers for schools program. So we do know that some larger districts have been able to go directly to some of the manufacturers and negotiate either bulk prices or sometimes even free. But they've always said to us when we've talked to these schools, well, the manufacturer didn't want us to tell you who they were because they didn't want everybody else to be coming to them with the same request. So I don't actually have a suggestion of manufacturers, but that is something to think about. That may be something that you can use, an action you can use yourself. I know one large urban district had funding from a nonprofit specifically for their first year, but that became unavailable later, so they had to include it in their regular budget. It's important to think about sustainability as you're looking forward and think of ways to be flexible in your funding. Another district had talked about how because they were concerned about inhalers then expiring but without being used all, they actually were able to find inhalers that had a 60 dose inhaler so that they were less likely to have that expire without being used. I know some other funding options that I've heard about were financial donors, either individuals or foundations, grant funding, and then general fundraising. I know that knowing that they use this often, really, I know one district I talked to said that they were able to show their district administration they used their inhalers 300 times in 1 year. Or within a month of we first got this in place, they used that in a month. So within that first month, so that really helped get things going. Some district protocols some districts, when they have put together their protocols and worked with their prescribers, they have decided to limit this for use for students with known asthma diagnosis. Now, the state law allows more generalized use, so it can be anybody on the premises, but some districts have chosen to limit that a little bit. I mentioned already that it's usually administered by the school nurse. Even when UAPs are well trained, they just are hesitant to administer a lot of these emergency medications, I find. Again, I already mentioned the telehealth. Data collection, again, can show the efficacy of a program. And I know that one district in particular was able to show that the EMS runs that to the school were decreased after they got this. Data collection is really important in showing how effective any kind of program is, but particularly this. So it helps you keep that in place.
And we've got
I know success stories. One district adopted a policy just this past fall and used it immediately on a student who was new to the district and didn't have their supplies yet. And another one, another school nursing program protocol in a school district allows one use by student, and then if they use it again, then there's a cascade set in place to get them coordinated with a hospital population health program to provide case management.
Okay, I'm going to give you the Reader's Digest condensed version on resources because we've been having so much fun chatting about asthma that we've gone a little bit long and we want to get to questions. So I'm going to kind of go through this rather quickly. If you have any questions on it later, don't hesitate to email me. Okay, we have our, at the network, our web address is right up there. We have our understanding guide for you to use. This is great with families. It's like an asthma 101 and can really help people understand what's going on. And then our respiratory treatments poster, which I've already sung its praises, but we do update this regularly. You may have one, it might be old. You might want to check that. We are going to be coming out in the next couple of weeks with this respiratory tools poster. So this will be something that will talk about spacers, nebulizers, peak flow. So this, watch for this. It's not even out yet. You're getting one of the first glimpses. We have an app which is amazing. It's called Asthma Storylines, and that's the look of the icon that you're going to want to look for as you go to look for it in your application store. This has a lot. Helps you journal, helps you manage, track your symptoms, and this would be awesome, I think, too, for a teenager because they could track their symptoms, and this might be a way to get them to actually talk to their doctor about their asthma because they'd be able to show them what was in the app. We have patient learning pathways, which are videos that are about 10 minutes long or less. And they, again, give you like an asthma 101, talks about asthma treatments, asthma medications. And then we've got this other very cool thing that we just finished not long ago. And that is we have our asthma medication assistance for patients. We've got a section of our website where you can see the picture of your inhaler, then what kind it is, what the name of it is, and a link if you need help to try to pay for your medications. Really cool resource. So at this point, we're going to come over here and look and see if you've written some questions in. And yes, you have. Somebody's asking where they can find state-specific data about stock albuterol. And do you want to try to take that one?
So I think it depends a little bit on the state. Some states do their own data collection where they to identify what the most common chronic illnesses are. I know that the child data and data collection, oh, help me, Sally, I'm forgetting the name of it. It's a national level child health data survey that's done, and they have a special asthma callback section where they come back to families and get more detail about if a child has asthma, what their symptoms are, etc. So that is another resource. There's a website for that.
Yeah, but I think too, just going to your state, I used to be a state school nurse consultant as well, and most states do have some data available. Our next question, I'll take this one, is how do you become a certified asthma educator, and should school nurses get certified? And you become a certified asthma educator. Basically, you've got such a knowledge base as it is. But then I got to tell you, I studied, I used flashcards, I took an Asthma Educator Institute course, but you take an exam. It's like the National Certification for School Nursing exam, but it's an asthma educator exam. And I think it would be awesome if every school nurse was a certified asthma educator because it changes a little bit how you think about things, but also I think it would be great to go to your district and say, look, I'm an asthma educator. Maybe you should pay me more. But I won't hold my breath on that one because then I'll turn blue. Okay, so can you give an example of a uniform data set for asthma in the schools? Can we answer that one, Anne, or is it going to take it's going to take a little bit too long, do you think, to get going on that one today?
Actually, data is another thing we could talk about for a week, so probably this is not the time to do that. Sorry.
Okay, no problem. So is a stock inhaler different than stock albuterol for a nebulizer as far as what you stock? Well, I think part of that's going to be what your law, because Anne, yours says it's an inhaler. So
yes, ours is very specific.
But I know that there are states that do have it in a nebulized form. Then you certainly have some different issues with that, including tubing and all this other kind of thing. So someone wrote in and said, I'm on the school board in my rural community, and this information has saved me some time and given great information to share on policy change in our district. Well, I'm so glad. So that's awesome. So next question, do some states use nebulizers instead of inhalers? Might be helpful to mention, and we just did. So, so someone's asking, are RN qualifiers for epinephrine use for a student? Does the student still need to go to the ER? When child has explained, has had an episode of anaphylaxis, they do need to be followed up in the ER. That is usually written into policies that the student would go directly to the ER. And the problem there too is, Anne alluded to this before. you give the epinephrine and the child's looking really good by the time the EMS gets there because you've done everything right. But with the anaphylaxis, you'll sometimes get a biphasic reaction, and they'll, without any other trigger, they'll have a second episode, and it can be serious, and so that's why they really do need to go. So I think that we are over our time as it is. And we had just a couple more questions, and I just don't think we're going to be able to get to them today. But I thank everybody for writing those in. I'd like to invite you to tune in for our next 5 Things to Know webinar. It's going to be on exercise and asthma. This is Allergy and Asthma Network's Mary Hart and Dr. Don Buckstein, and they are going to chat with you about exercise and asthma. Mary is a respiratory therapist and also our director of research. That'll be on February 27th at 4 p.m. Eastern Time. So thank you so much for listening. We're going to have this webinar. It's been recorded. We're going to have it on our website, and you'll be getting a follow-up email telling you where to find it. So again, thank you so much for listening, and Anne, thank you so much for being with us today.
Thank you. It was a pleasure.
Take care, everybody.